to the Home of Medicine podcast with me, Dr. Amy Burbridge. I'm a consultant in acute and general medicine in the UK, and today I am joined by...
Hello, my name is Ben Lovell. I'm a consultant in London in the UK in acute and general medicine also, and I do a lot of medical education.
Thank you so much for joining me again today, Ben. You've got a case for me, so let's start.
Let's start. So this is a case of a patient I saw when I was a registrar, actually, but it's something has stayed with me. So hopefully you and those who listen will get something out of it. And it's a story about when I was a medical registrar and I was asked to review a patient on the surgical ward. The surgeons rang me for a medical opinion. And it was for hypertension, a persistently hypertensive patient. So that sounds easy peasy. Any acute and general medic can manage hypertension with their eyes closed, but it gets a bit more interesting than this. It actually was a 27-year-old woman, and she'd been admitted to the surgical ward with severe, but thus far unexplained abdominal pain. They'd done blood tests, they'd done CT scans, and they had not shown any pathology, but she was persistently in very, very severe abdominal pain. And they called me because she'd been persistently running a blood pressure of around about 150 over 100 since she arrived and throughout all of her treatment. And they wanted me to possibly diagnose hypertension and initiate treatment because this was higher than usual for a 27-year-old. And her surgical story really was admitted. She was day 3 of admission with unexplained severe abdominal pain. She had occasional vomiting, but not massive vomiting, and no diarrhea or severe constipation, really. So it was unexplained. And the abdomen was profoundly tender, but not peritonitic on examination. So I went to review the patient. She was clearly in pain despite having quite a lot of opiates. And looking at her notes, it looks as though she'd had recurrent abdominal pain for the last year. But this was the first time she'd presented to A&E with it. And initially she'd been CT'd in A&E and discharged, and she came back later the same day in severe pain. And that's how she ended up on a surgical ward having ongoing tests. She'd never been told that she had high blood pressure before this admission, and she did have a painful abdomen, but otherwise there was nothing really interesting to elicit. She had no medical history before coming in. She had no drug history before coming in. So what do you think of this lady with her blood pressure of 150 over 100?
Okay, so the first thing I want you to do is a pregnancy test.
Mm-hmm.
Just to make sure that she's not pregnant, because every woman's pregnant until proven otherwise. Okay, so if she's not pregnant,
pregnancy test was negative. Yeah, done and negative.
Okay, so that blood pressure doesn't necessarily worry me too much. I've seen a lot higher, but in a 27-year-old female, yes, it's of a concern, particularly with the background of abdominal pain. Is she hypertensive because she's in pain?
That was my initial thought. I thought, I'm not worried about this. Treat her pain and then see what happens. I think a lot of people, because she was occasionally going to like 180 over 110, then down maybe to 150 over 90, but averaging 150 over 100. You see systolic hypertension with pain a lot. At that point, I hadn't really seen diastolic elevation with pain, but it certainly made a lot of sense to me that she would have it. So I wasn't worried. People get very worried about inpatient readings of high blood pressure. Oh my gosh, they're going to have an aneurysm or a stroke or something. And a lot of, I think, the med-reg role is like, it's okay, slowly, you chip away at blood pressure. You don't, completely deflate it in one go. And I said, maybe she just needs better pain control, was my first instinct. Does that sound reasonable?
I completely agree with you, Ben, that actually if we manage the pain, then the blood pressure should come down. And I assume that you managed the pain and the blood pressure didn't change.
Yes. Also, as a side note, I'm really not a fan of starting antihypertensives and inpatients, or even augmenting antihypertensive therapy in inpatients. I know I have read a paper on this, but I wish I could remember the title of it. But it was saying that if you do intensify or start antihypertensive treatment in inpatients, they have worse outcomes in the long run. And I think the reasoning is, it's a stressful time to be a patient. They go home into their home environment, their blood pressure drops 20 points, and then all of a sudden they've got iatrogenic syncope and drug-induced hypotension, and they fall over and break hips, etc. So I've always been a bit yucky about starting any kind of antihypertensive treatment on an inpatient anyway, just because I think that it's probably does the patient a disservice in the long run.
Do you know, I completely echo that, because one of my biggest bugbears that I've seen in same-day emergency care over the last 6 months is an increasing number of people being referred for hypertension. manage accordingly. And I'm like, well, actually, are they hypertensive? Because they're in hospital, they've been waiting for 4 hours, and I never start antihypertensives in hospital unless it's a hypertensive urgency or emergency. And what I'll often say to the patient is, buy yourself a blood pressure monitor at home, take your blood pressure 2 to 3 times a day, different times of the day, keep a diary of it. Mm-hmm. And go and see your GP, in 2 to 3 weeks. And actually, occasionally they have come back and see me. I had a lady a few weeks ago who'd actually come back to see me who did have quite high blood pressure, was only young, did a blood pressure for a week, came back, and actually it was completely normal.
Yeah, you have to tell them only do it 2 or 3 times a day, though, because that home BP monitor is quite addictive. And sometimes they come back with a measurement every 50 pages of the stuff. And I think that actually induces hypertension.
Yes.
They sit and panic. So you have to be quite strict with them.
Yeah, I have seen that actually. Yeah, when they that's a very good point. Just morning and evening is absolutely fine. Yeah, very good point.
Sit down, and then do the blood pressure. So my gut feeling was for them to have suboptimal pain control, really. Although I did look at the blood test and there was a couple of small abnormalities on there. The full blood count was normal except for a very tiny white cell rise up to 14, the upper limit being about 11. Her CRP was 13, so in my book, ignorable. And her Usinese renal function was normal, but she had a hyponatremia of 128, the cutoff being 135 at the lowest end of normal. Her bone profile was normal, and her LFTs they've done were normal, except for her ALT was slightly elevated at 61. I mean, that's not much at all. So really hyponatremia of 128, which I couldn't quite explain. She wasn't on any medications which would cause hyponatremia. And her fluid status to me was euvolemic. So I don't think, was she vomiting and had hypovolemic hyponatremia, or it's not really overload dilution hyponatremia. So euvolemic hyponatremia in a young person, is it SIADH or is it psychogenic polydipsia, and she's drinking 10 litres of fluid a day? But I like to be helpful, so I suggested the hyponatremia screen to the surgeons, which basically was, let's get a urine, sodium and osmolality, and then we'll know. And examining the patient, I did check for a goiter because just in case she's got thyroid, overactive thyroid, which could be driving this, and there was no palpable goiter. In fact, her examination, apart from a tender but soft abdomen, was very normal. Euvolemic, as I said, no signs of failure, afebrile. Blood pressure was consistently elevated, about 150 over 100, sometimes higher. And her heart rate sat between 90 and 110, but the 110 coincided with really severe bouts of pain. Yes, but no goiter, as I say. So I suggested, why don't you do the TFTs, a simple hyponatremia screen, and then you can treat the pain. And then we can just watch and wait. She's not at risk of any hypertensive urgency with those numbers, and I can't see any evidence of hypertensive urgency on examination looking at her blood tests. So we have a bit of wiggle room here, a bit of breathing space. And just to complete the narrative for you, her past medical history contained nothing. She, medication-wise, she started the oral contraceptive pill a few months ago, maybe a year ago, but otherwise took no medications. And socially, she was a non-smoker. She was Polish. She'd come to the UK with her boyfriend for studies, had occasional alcohol, but no recreational drugs. And that was her, really. Anything I've missed out there, or anything that you would be thinking about in that story, or is it sort of cut and dried?
Okay, I've got a couple of questions. So number one, you talked about the sodium. What was her potassium?
4.1.
Okay, so that's normal. So creatinine and urea?
Urea was 3.1 and the creatinine was 62.
So normal.
Range. Yeah.
Okay. Periods. So you said that she's on the oral contraceptive pill. Is it the combined or progesterone only?
Combined.
Okay, so she's having estrogen and progesterone. And was she having periods, and were they regular?
Yeah, she had regular periods 1 week a month when she had her dummy week she had her week off the pill.
Okay, so they weren't very heavy or abnormal like that or anything like that? No. Okay. No past medical history of no medications. You said no drugs, so no cocaine abuse?
No, none of the above, no.
Yeah. Any family history of any weird and wonderful sort of like hypertensive cardiac conditions?
No, and I asked specifically, but her family history was very, very, there was nothing in there at all.
So we have a 27-year-old female, fit and well, with severe bouts of abdominal pain. hypertensive, bloods are pretty much normal. Examination, was she, did she have a high body mass index?
No, she was slim.
Okay. So actually, I think what I would do in this situation is, like you say, you took a history, you've asked about the abdominal pain. Did she have any urinary symptoms?
Urinary symptoms?
Yes.
No.
No. Any rashes?
No.
Any rheumatological signs or symptoms? So any hair problems, joint problems?
No, although in the spirit of true honesty, I did not go into that deeper dive with her on that review, but ultimately, no.
Okay, so the only thing I'm thinking of is this is really random. I mean, is it scleroderma? Does she have hypertension secondary to scleroderma? Systemic sclerosis can have abdominal complications. I mean, that's really stretching, isn't it?
Well, she didn't have any. I'll tell you that she didn't have any peripheral scleroderma that I could see. There was no sort of typical scleroderma facies that you would see or anything like that, or any telangiectasia or signs of Crest syndrome. So I didn't pick up anything like that.
Okay.
At that point, I literally wrote in the notes my assessment, which was high blood pressure in the context of pain and hospitalization was my diagnosis. Also slightly deranged LFT with an ALT that was a little bit above normal range, and hyponatremia in the context of euvolemia. And I said, do the hyponatremia screen, manage her pain, and then call me back if there's any ongoing concerns. And they did. And the next day, I was still the med reg on call for the wards, and they ran back and said, look, her blood pressure is still 150, 160 over 100. We're wondering whether this could be functional or she's got no surgical problem that we can identify. Her sodium is stuck at 128. Please, can you come and have a look again? We don't have any of the hyponatremia screen results back. And I think it was a case of, can you come and see again, with a little bit of unwritten subtext of, look, can you take this patient over, because we don't need to operate on her, and I think she's got a medical problem. So I went back to see her. She was still struggling with pain, still struggling with her blood pressure. In the interim, the surgeons had asked for a gynae review in case she could have something like endometriosis that could explain it. But the gynae team had seen her. They said they felt that was really unlikely there was any gynae pathology there. And we finally got back the hyponatremia screen, and the urine osmolality was well over 100. And the urine sodium was more than 20. And I'll tell you straight off the bat, so don't think, both in keeping with SIADH. At that point, I was sort of stuck. And I went back and spoke to my supervisor, who was a consultant. And I said, I've got a patient I don't know what to do with. She's unexplained hyponatremia, probably SIADH, but in the context of bad abdominal pain, which no one can explain, and persistent hypertension. And I got about that far. My consultant went, she has porphyria.
So I'm just going to show you something. I know you can't see it, but I've actually just wrote that down.
No, show it to me. I don't believe you.
I swear to God, look.
Well, she has written it down, yes.
Where is it? I have. Yeah. It's got a porphyria.
Acute porphyria. She wrote it down. Amy, well, you got there faster than me. And I was amazed. And I sort of went and looked it up, and oh my goodness, she does. Acute intermittent porphyria, AIP. You went, oh yeah, she's got it. And I said, how did you get there so quickly? And you went, I've seen this case before. And we always talk about pattern recognition on this podcast, and had the different ways of getting to a diagnosis. And at that point in my career, the only way I could get a diagnosis was using the good old-fashioned hypothetical reasoning, which was sort of adding all the symptoms together and then trying to find the Venn diagram in my brain where they overlap and what the diagnosis is. And that's great when you're setting out. But if you've got a case in your back pocket that you can immediately match it to, bingo, you sometimes get the diagnosis very quickly. And I found that profoundly exciting. It's acute intermittent porphyria. Yeah, we'll accept her under the medics, but that's what it's going to be. And that's what she ultimately had. And then I went and did some reading, and my goodness, she was textbook. Shall I give you a quick overview?
Yes, please, because I have to say, I've seen one case of porphyria in my career, presented with abdominal pain in a young female. I mean, absolutely, you're right. It's that using that bias, isn't it, of those patients that you've seen before, but also that's got me into trouble sometimes with this hindsight bias. Oh, I've seen this exact thing before, it must be this, and it isn't. And I'm like, oh God, never mind. I thought I sounded intelligent.
Leads me down the wrong path.
Absolutely.
I guess as long as you're then going to test your hypothesis by saying, let's test for this condition, because I've seen it present like this before, and keep an open mind to that not being the case. But Yeah, I was looking up. So I went and looked up acute intermittent porphyria, and basically I read a description of this patient, which was fascinating. It's usually young women, as you mentioned, usually young women in their 20s or 30s. My patient was 27. It's often latent for many generations. There's often no family history, and it's an autosomal dominant condition. And 90% of gene carriers actually have no attacks, but because of incomplete penetrance of the gene. So that's why there was no family history worth noting. And I read the description of a typical attack. It said they often present with some psychiatric phenomenon. She did not have this at all. She had none of the agitation or depression or hallucinations, which can sometimes be described with it. But otherwise, abdominal pain attacks, tick, tachycardia, tick, vomiting, tick, hyponatremia in 40% of sufferers during an attack, which presents like SIADH, tick. Triggers include oral contraceptive pill, tick. Mild ALT rise, tick. High blood pressure, tick. I was absolutely astonished that she was, lighting up all of these different things. But I couldn't get there because I didn't have any history of seeing the diagnosis before. Maybe I would have eventually got there on my own if I really hit the books, but my gosh, we got there quicker. And so the test, of course, is looking for urine, urine accumulation of the porphyrobilinogen and genetic testing ultimately. And that was the case. And that stayed with me. And this is probably about 10 years ago that I saw it, but I always think of it now. And I guess a young person or any person who comes in with severe abdominal pain, we put them through the magic CT scanner of truth and work out what it is. And I think sometimes if it doesn't show any pathology, we often stop thinking, or we say it'll settle down. Goodness knows how many people get labeled with IBS. And in fact, there is a whole host of very beautiful but rare medical conditions that can present with severe abdominal pain that we should mentally run through in our internal Rolodex and sort of rule in or rule out with some very, very simple tests.
Yeah, I absolutely, completely agree. It's one of those conditions as well, when you see one of these really rare conditions, when you've seen it once, you'll recognise it the next time, and the time again and the time after that if it does happen. You mentioned that they often present with psychiatric signs and symptoms. So what sort of psychiatric symptoms may they have?
Depression, hallucinations, persecution, paranoia. And if you look, it's hypothesized that many, many famous people from history actually were AIP sufferers, like Vincent van Gogh. They say probably could have had it with a combination of neurosyphilis as well. But he ticked all of these things off as well. But that's due to the psychiatry, and it's due to the accumulation of the porphyrobilinogen. If you meet someone who's got it, the treatment really, like all metabolic disorders, I've noticed, the initial treatment is to give them glucose. They need lots of carbohydrates. So 10% dextrose infusion in the short term really helps all their symptoms. Untreated recurrent attacks of AIP result in permanent damage to nerves, which is a irreversible peripheral neuropathy, for example, seizures, even death. And what I didn't know was that the only true curative treatment was a liver transplant, which I wonder how many people actually go on to get. And you give IV heme as well. So I look for it now a lot, and I never found it since, but I think maybe one day I will. And now maybe you will, and people listening will at least consider it.
Yeah, absolutely. It's one of those things that when you've heard about it, it's like autoimmune encephalitis. That's another thing that when you've heard about it and you've seen it once, actually you think, I've probably had quite a few patients who've had that and have actually missed it because it's so rare, such specific signs and symptoms. But when you get that diagnosis, it's obviously very good for the patient, but also it's quite satisfying, isn't it?
Yeah, and I have seen at least a couple autoimmune encephalitides in cases in my career. And probably you're right, there's a bit more of it out there than we all appreciate that there is. But goodness me, it's a difficult because it mimics everything, doesn't it?
Yeah, exactly. That was a really interesting case, I guess. I mean, from as a trainee perspective, that's a very challenging diagnosis to get because there's no specific test that you can do quickly to get there. So you're going to have the bit of a low sodium, raised ALT, maybe slightly raised white cell count. And obviously the diagnostic test is not something we do every day. So do you have a system that if you've got somebody who's got these really weird signs and symptoms, for how you can think about casting that net really broad to really try and identify what is going on?
I think for me, if someone comes in with symptoms with no explanation, and you yourself have reached the limit of your brain power, like you really are scratching your head, for me, I would advise there is so much power in getting a second pair of eyes on it, even as a consultant, medically unexplained symptoms. Sometimes talking to a colleague informally in your office can, like I did with the consultant, they can just throw up a wild card and go, oh, it must be this. Or have you considered testing for something? But even if you were maybe an outpatient, referring to a colleague for another opinion is a really, really powerful thing to do if you get stuck. I'm not one for saying, let's just do every single test you can do at the first instance you meet a patient and see what the positive comes. I really think you've got to have a preclinical suspicion before you order a test and then know what you're going to do with the result. But in terms of things like abdominal pain, which is a completely non-specific, what's another one? Fatigue, so non-specific and so common. I think everyone has their own personal way of working through it. And I think there are many guidelines out there for how to investigate non-specific fatigue, but then they stop, don't they? They say, or there's a box and it says, if all negative, explore other rarer causes. And that leaves you to go, goodness, what on earth are they going to be? So that's a situation where I think getting a second brain in is absolutely vital. And I don't know about you, but even as a consultant, asking a consultant colleague who is not necessarily more experienced than me or has more years under their belt in the NHS than me, but just as a new, fresh perspective on a clinical situation is really, really useful. And you can be any level of doctor, any level of experience and use that as a tool.
Yeah, I think, decision making, particularly around uncertainty, should be a team sport. And actually, we shouldn't, the best teams in the world, you're not working alone, are you? Even, when you look at sports, even tennis players who play singles, they've still got this whole team around them who are supporting them. And it's the same in medicine. Just because we're a consultant, we shouldn't be making all of the decisions. So I will often ask for help and say, I have got a clue what's going on. Can I just have some help? Any suggestions, any ideas, any tests you think I've missed? And also, to echo your point, I am very much anti, let's do 2 million tests and let's somewhere in that the diagnosis will be. And, we live in a finite resource. And I really think that we should, respect that, and not somebody comes in with abdominal pain, not then doing every single investigation under the sun, but we should do our tier 1 tests. Okay, our basic ones. Let's think of what are our hypotheses. Let's confirm or refute that. Nothing's come out. So let's go to our second level investigations and third level. But, we shouldn't be doing CT angiograms, I don't think, at the front door, unless it's obviously clinically indicated.
You don't respect that. That's when you end up with all of these D-dimers and troponins that you didn't really want. And now you've got to try and force it into a diagnosis that doesn't quite fit.
Yeah, and it's that slightly elevated D-dimer referral to SDEC is a struggle, because it will often come. I saw this patient last night. They came with chest pain. Their D-dimer is 0.58. The upper limit of normal is 0.5. Please do a CTPA. Well, actually, if you take a history and examine the patient, they have no signs or symptoms suggestive of a PE. Do I then have to do that CTPA because the patient's expectations are they've come into hospital for that test? And I find that really challenging sometimes to try and unpick that and identify what's the best course. Normally, I'll go back, retake the history, re-examine and explain to the patient, actually, I think it's highly unlikely that you've got a PE, so I'm not going to do the scan. Like you said, whenever we do a test, we should always be looking at the sensitivity and the specificity of the test to make sure we understand it. But also in the case of a D-dimer, we should be doing them when a patient has a high clinical probability of a VTE. But D-dimer is just a box that's ticked. And it's like, but they didn't have a clinical probability of that. And now what am I going to do with that D-dimer? And that can also be a challenge. It's one of I struggle with a D-dimer. What about you?
You can extrapolate it to CT scans that pick up incidentalomas, which then require a biopsy, or what's another one? Troponins are people who had a syncopal attack and now you've got to do something with it, but they've also got renal failure and that could explain it. And I think there's all sorts of things you pick up on tests. Unless you really want the test, be prepared to pick up your incidental, unexpected findings that now you, as the clinician, have to make sense. And sometimes that can be really tricky.
Yeah, absolutely. I just wanted to, I think we've talked about this before, but when I have a patient who I struggle to know what's going on, I use the vitamin D, where I go work through it and say, I've got abdominal pain. So V's for vascular, are there any vascular causes? I, infection, any infective causes. T is for trauma. A is for autoimmune. Then we've got metabolic. Then we've got iatrogenic. Then we've got neoplastic. And then we've got drugs. And actually, I guess if we'd gone through that vitamin D and thought metabolic, to be honest, I probably wouldn't have even mentioned porphyria then. Even though it's a metabolic cause, it's somewhere so far down on the list.
That's interesting, because where I trained up in Newcastle upon Tyne, we had a vitamin CHO. Now, the CHO stood for CHO was congenital, hypertrophic and obstructive. Vitamin D is better, I guess, because it's got drugs in it. And goodness me, with the drugs we give patients these days, cause all sorts of problems. And we're not going to be diagnosing people with congenital disorders in later life and adult medicine, despite what the PACES exam believes that we should be doing.
Yeah, that's a good point, actually. Although I do quite like congenital in there because it makes you think, but I guess it may or may not be relevant in some cases. So moving on, what are your key takeaway points for today's case, Ben?
Well, I would say, first of all, is porphyria exists. The prevalence is 5 in 10,000. I mean, that's higher than some diseases we see more regularly, like Guillain-Barré syndrome. So it's out there. And I think these are people with unexplained recurrent bouts of abdominal pain. We sometimes think, familial Mediterranean fever, but I don't know how often we think, recurrent serious porphyria attacks. So it's out there, it's easily testable. And that little cluster of features, maybe now I've given you this patient, you might remember it. So when you see that hypertensive, hyponatremic patient, young woman on the pill with a recurrent bout of abdominal pain, it might come further to the top of your consciousness. So that's the whole point of what we're doing here. So hopefully that has landed. And if I can steal another learning point, I'm going to steal yours. And I can't remember how you phrased it, but you said managing uncertainty is a team sport. Is that what you said?
Yeah, absolutely.
I'll have that one as well.
Yeah, okay. Excellent. Yeah, fantastic. Thank you so much, Ben, for joining me today on this podcast. You have definitely reminded me that acute intermittent porphyria exists. I'll probably go to work tomorrow and diagnose about 5 people with it, with my, my recency bias. I won't really, but I'll be there on the tip of my tongue. So thank you very much. Thank you to all of our listeners out there. And I hope you've enjoyed listening and taken away some of those fantastic learning points from Ben. And we'll be back soon. Thanks for listening.
Thank you. Bye.
You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.